Teamwork cannot occur in the absence of a clearly defined team. Therefore, improving upon an existing or defining a new team structure is the first step in implementing a teamwork system in any environment. Organizational researchers have long focused on the value of teams as a unit of task work, with leadership serving as a means for improving employee performance and attitudes. It is important to first understand the structure of teams to learn how to promote teamwork and create a climate conducive of effective team functioning. Such a climate is based on a commitment to collaboration, mutual accountability, acknowledgement, recognition, and professional respect. Upon completion of this module, participants will be able to identify the characteristics of high-performing teams, discuss the benefits of teamwork and team structure, describe the components of the composition of a multi-team system, including core team, coordinating team, contingency team, ancillary services, and administration, understand what defines a team, and define the roles of effectiveness of team members. Team structure is an integral part of the teamwork process. A properly structured patient care team is an enabler and the result of effective leadership, communication, situation monitoring, and mutual support. Team structure is the glue that holds together an effective strategy for ensuring patient safety and reducing medical errors, taking into account the knowledge, performance, skills, and attitudes of medical team members. A key concept of team structure is partnering with the patient. Patients are part of the patient care team and should be embraced and valued as contributing partners to patient care. Evidence shows that giving patients a greater role in their care can improve their health. Patient-centered care is grounded in respect and action. Ways to effectively involve patients in their own care are to include the patient in rounds, involve the patient in key committees, involve family members. This is an indirect care, and actively enlist the patient's participation. Learning to work with patients and families as true partners is neither easy nor intuitive. Learn to listen. Ask patients how involved they prefer to be in their own care. Before launching into detailed status, ask patients about their concerns. Otherwise, they might not listen to or understand what is being said to them. Speak in lay terms so that patients are not inadvertently embarrassed because they do not understand what is being said. Give patients and families access to relevant information. Ask patients and their families for feedback and to be proactive participants in their care. They are also responsible for transforming relationships between healthcare providers and patients. For example, the Josie King Call Line. The program enables parents and family members to call for immediate help if they feel the patient is not receiving adequate medical attention. The goals of teamwork are to reduce clinical errors, improve patient outcomes, improve process outcomes, improve patient satisfaction, increase staff satisfaction, and reduce malpractice claims. Teamwork may be determined by the physical layout of facilities. Parts of units housed together may be considered teams. What are some other benefits of teamwork? Over the course of this training, we will touch on the many interrelated aspects of high-performing teams. Generally speaking, high-performing teams have some common traits. One is shared mental models. Let's discuss this. In what way do shared mental models contribute to the success of high-performing teams? The answer is members can anticipate each other, coordinate without the need to communicate overtly, know when explicit communication is best, and know where to look for expertise. Other traits of high-performing teams, which we will explore in more detail later in this course, include having clear roles and responsibilities, have a clear, valued, and shared vision, a common purpose, an engaging purpose, and a leader who promotes the vision with the appropriate level of detail. Optimize resources. They have a strong team leadership. Engage in a regular discipline of feedback. They regularly provide feedback to each other and as a team. Establish and revise team goals and plans. Differentiate between higher and lower priorities. Have mechanisms for anticipating and reviewing issues of team members. Periodically diagnose team effectiveness, including its results, processes, and vitality, which include morale, energy, and retention. They develop a strong sense of collective trust, team identity, and confidence. They manage conflict by effectively confronting one another. Have a strong sense of team orientation. Trust other team members' intentions. Believe strongly in the team's collective ability to succeed. Develop collective efficiency, and have a high degree of psychological safety. They create mechanisms to cooperate, coordinate, and generate ongoing collaboration. They identify teamwork and task requirements, ensure that the team processes the right mix of competencies through staffing and development, distribution and assign work thoughtfully, consciously integrate new team members, involve the right people in discussions in a flexible manner, and examine and adjust the team's physical workplace to optimize communication and coordination. The last is they manage and optimize performance outcomes. They communicate often and at the right time to ensure that fellow team members have the information they need to contribute. They use closed-loop communication, learn from each performance outcome, and continually strive to learn. There are also many barriers to effective team performance. Inconsistency in team membership, lack of time, lack of information sharing, hierarchy, defensiveness, conventional thinking, varying communication styles, conflict, lack of coordination and follow-up, distractions, fatigue, workload, misinterpretation of cues, and lack of role clarity. Can you provide examples of how some of these barriers might play out in your clinical environment? Now let's look at the team in your own work area. Please take a few minutes to complete the Teams and Teamwork exercise sheet. Who are the team members in your area or unit? What is the goal of your area or unit? And what properties or characteristics make a group a team? This slide shows the model of a multi-team system, or MTS. Each team within an MTS is responsible for various parts of patient care, but all must act in concert to ensure quality patient care. The multi-team system is composed of several different teams. For example, an MTS structure within a family practice clinic. The core team would be the physician, nurse, and administrative staff member responsible for treating a patient. They come in direct contact with the patient, making them the core team. The contingency team may consist of a pharmacist or PharmD who can be called upon to participate in the event the medication regimen is complicated and requires special pharmacological expertise. The coordinating team in this example might include the clerk checking in the patients for each core team and the physician, nurse, and enlisted person responsible for that day's triage, resource management, and promotion of teamwork for this clinic. The second example is an MTS structure within a tertiary care facility. The core team may be composed of the physician, nurse, and cardiac catheterization laboratory staff member responsible for performing a coronary angiography and dilation on the patient. They come in direct contact with the patient. The contingency team may consist of the cardiac surgeon, anesthesiologist, and operating room staff who can be called upon to participate in the event the patient requires emergency surgery. The coordinating team, in this example, might include the chief nurse or physician responsible for triage and resource management for the intensive care units. Core teams consist of team leaders and team members who are involved in the direct care of the patient. Core team members include direct care providers from the home base of operation for each unit, and continuity providers, those who manage the patient from assessment to disposition, for example, a case manager. The core team is based where the patient receives care. Core teams should be small enough to ensure situation monitoring, development of situation awareness, and direct, unfiltered communication between members. To establish a shared mental model, core teams should be large enough to include skill overlap between members to allow for workload sharing and redistribution when necessary. Every core team has a primary leader who is readily identified by all members of the team. When multiple core teams exist in a unit, a method for denoting team affiliation is established to expedite information flow and resource coordination within the teams. A team distribution scheme denotes the assigned work area of each core team and facilitates the allocation of resources across the unit based on fluctuations in team workload. Core team leadership is dynamic. Core team leaders are required to take on different roles at various points in the plan of care. Often these may be non-leadership roles, such as supporting a nurse starting an IV. To establish a core team, first select a leader, designate roles and responsibilities, and communicate essential team information. The coordinating team is the group responsible for your day-to-day operational management, coordination functions, and resource management for core teams. Direct patient care may be a secondary function with the exception of small facilities. Coordinating team leaders generally are designated. Multiple role groups are usually required for each unit. It is the role of the coordinating team to provide policy-level guidance, triage all emerging events, and prioritize decision-making to ensure maximal support to the core team. Coordinating team members facilitate core team actions and outcomes by collaborating with the administrative team and the ancillary services team to assign priorities and ensure throughout. It is also the coordinating team's responsibility to make certain that potential contingency situations are recognized and that the contingency team is notified of potential activities. Coordinating teams frequently comprise experienced personnel with a strong clinical background. This combination enhances the ability of the coordinating team members to rapidly assess the overall picture, anticipate the needs or potential needs between and across teams, and make priority-based decisions. Let's pause and talk about who might be the members of the coordinating team for an outpatient clinic, and who might be the members of the coordinating team for a hospital. Contingency teams are formed for emergent or specific events. They're time limited, so code teams, disaster response teams, and rapid response teams are very limited, composed of team members drawn from a variety of core teams. Rapid response teams are a group of caregivers available to respond to a patient's bedside whenever a nurse or other caregiver feels a patient's condition is deteriorating. Contingency teams are responsible for immediate, direct patient care during emergent situations requiring more resources than are available to the core team. They generally consist of pre-identified members deriving from varying units or core teams and have limited time to prepare for emergencies. Contingency team roles can be very specific and limited to a certain situation, such as a code team, or have general responsibility for a broad category of situations, such as a disaster response team. The more general the responsibility, the greater the need for clear and unambiguous policy guidance from the administrative team to facilitate rapid decision-making and clear assignment of responsibilities. In most cases, these teams do not spend much time together, and the situations that they deal with are ever-changing. Their roles are clearly defined, and leadership is designated based upon the needs of the patient and member expertise in dealing with the particular situation. Ancillary services consist of individuals who provide direct, task-specific, time-limited care to patients. They support services that facilitate care of the patients and are often not located where the patients receive their routine care. Ancillary services are primarily a service delivery team whose mission is to support the core team. In general, the ancillary services team function independently. Support services consist of individuals who provide indirect, task-specific services in a healthcare facility. Integral members of the team who are service-focused, helping to facilitate the optimal healthcare experience for patients and their families. Roles are integrated in that they manage the environment, assets, and logistics within a facility. Support services are primarily a service-focused team whose mission is to create efficient, safe, comfortable, and clean healthcare environments, which impact the patient care team, market perception, operational efficiency, and patient safety. What are some examples of ancillary and support services teams? Administration includes the executive leadership of a unit or facility and has 24-hour accountability for the overall function and management of the organization. Administration creates the climate and culture for a teamwork system to flourish by establishing and communicating vision, developing and enforcing policies, setting expectations for staff, providing necessary resources for successful implementation, holding teams accountable for team performance, and defining the culture of the organization. The administrative team has no responsibility in the direct delivery of care, but provides the framework and guidance that ensures each team understands its roles and responsibilities and has access to the necessary resources to be successful. The administrative team also holds everyone accountable for exhibiting teamwork behaviors. For all teams to function effectively and provide the necessary mutual support, it is critical for the administrative team to develop and institutionalize proper policies and procedures that clearly articulate the roles and responsibilities of the other teams and team members. Administration should strive to create a learning culture where there is trust and transparency, to create a safe harbor, to report, analyze, and share information openly. This philosophy serves to define a culture of safety. However, just as in aviation and other high-risk industries, the change will not happen overnight. Here we see an example of a multi-team system in the operating room. In this example, the core team consists of the surgeon, anesthesia, the circulating nurse, and the scrub technician. The coordinating team consists of the charge nurse, an anesthesiologist, and a unit clerk. The ancillary services team consists of radiology, pathology, and housekeeping. The contingency team consists of anesthesia. Administration consists of director of surgical services, the nursing director, and perioperative services. Individually, map out a multi-team system for your clinical environment, unit, department, work area, or ward. Think about what types of team members make up each team, and how do the teams in your unit or ward interact with one another. Now that we have examined the structure of teams within a given unit, we are going to look at team leaders and team members. Please consider how the lack of team structure plays a role in the situation shown in this video.
This is Michelle Keys. She's a 27-year-old prima gravida at 41 weeks. Her blood pressure was 135/70 on admission, and her urine dipstick was only traced for protein. Cervix is 1 centimeter dilated, 25% effaced, and -3.
Her first blood pressure in the clinic today was 141/88. The repeat was normal. We'll need to keep an eye on her blood pressure. She could be developing preeclampsia.
Let's run a type-in screen and a CBC. We need to check her liver functions and uric acid level. Dr. Upton wants us to start an induction on misoprostol intravaginally. I think that's 100 micrograms, right? That's right, 100 micrograms.
Janet, who's coming in for you?
Dana Collins. I'll talk to her about the patient.
Hi, Janet. How are things looking tonight?
Hi, Dana. I am late to pick up my kids at the sitter, so I need to make this quick. We have a 27-year-old prima gravida who's had an uneventful pregnancy. She has been admitted at 41 weeks for induction with an unfavorable cervix. Poor thing has been waiting for a bed since early this afternoon and just got admitted.
That long, huh? Well, how's she doing and who's the attending?
She's stable right now. The attending is Dr. Upton.
We're doing a stat section in room 15. I need your help moving the patient to OR.
Right, I'll be right over. So nothing but the usual, right?
Right. Sorry, I'm in a rush.
Okay. Dr. Pham, could you please take a look at this fetal heart rate tracing? We're seeing some late decelerations.
She's at 6, Dr. Dean. You think we should call Dr. Upton?
No, I think we can handle this without him.
Dr. Dean, it looks like these decelerations are getting even more severe.
Dr. Dean, do you think we should consider a C-section?
No, not yet, anyway. This looks okay.
Dr. Dean, the baby's heart rate's been in the 60s.
Let's continue to monitor.
It's been like this for 3 minutes.
We need to do a crash section. Get Upton in here. Now!
Albert, Jim, I can't believe the two of you. How long have you been here? This baby nearly died. What were you thinking? There's just no excuse for this.
Now let's discuss what you saw in the video vignette. Did the team members communicate essential information to each other? No, vital details were forgotten or not included, and no mechanisms were in place to support collaboration and information sharing. Competing tasks and distractions were another factor. Did the team demonstrate mutual respect toward one another? No. For example, Dr. Upton did not demonstrate respect to Dr. Dean upon expressing his disappointment in the way he handled the situation. Instead, he attempted to lay blame. Did the team address issues and concerns? No, when concerns were raised, they were ignored, with conflict replacing collaboration. How could the team have partnered with the patient better? The team could have asked how the patient preferred to be involved in her own care by asking questions, listening to her concerns, and giving her access to relevant information. What were the barriers to team performance in this vignette? Lack of coordination and collaboration, delayed decision-making, lack of role clarity, conflict, lack of information sharing, and misinterpretation of cues were the barriers to team performance. Which traits of high-performing teams were lacking most in this vignette? Regular discipline of feedback and communication, clear roles and responsibilities, strong team leadership, mechanisms for coordinating and collaboration, and team trust were lacking most. A team is different from a group. A group can achieve its goal through independent individual contributions. Real-time coordination of tasks between individuals is not required. A team consists of 2 or more people who interact dynamically, interdependently, and adaptively toward a common and valued goal, have specific roles and functions, and have a time-limited membership. During the temporal life of a team, the team's mission is of greater value than the goals of the individual members. Team members include anyone involved in the process of patient care who can take action, including the leader, have clearly defined roles, are accountable to the team for their actions, and must stay continually informed for effective team functioning. Moving to a team system approach will result in a number of shifts in traditional work patterns. You're going to see a shift from a single focus, clinical skills, to a dual focus, clinical and team skills. It'll go from individual performance to team performance, from under-informed decision-making to informed decision-making, from a loose concept of teamwork to a clear understanding of teamwork, from an unbalanced workload to a managed workload, from having information to sharing information, from self-advocacy to mutual support, from self-improvement to team improvement, and from individual efficiency to team efficiency. Effective team members are better able to predict the needs of other team members and are proactive versus reactive. They provide quality information and feedback, engage in higher level decision making, manage conflict skillfully, understand their roles and responsibilities, and reduce stress on the team as a whole through better performance. Effective team members achieve a mutual goal through interdependent and adaptive actions. Teamwork actions include assembling a team, selecting a leader, identifying the team's goals and vision, assigning roles and responsibilities, holding team members accountable, actively sharing information among team members, and providing feedback. Vince Lombardi says, individual commitment to a group effort, that is what makes a team work, a company work, a society work, a civilization work. What actions will you take to improve your team structure and effectiveness?